Hello and welcome back to another episode of Taking Control of Cancer, the podcast brought to you by the North East London Cancer Alliance. I'm Steve Bland, and this podcast is a bit of a how-to guide for you to help you overcome common myths, fears and barriers when it comes to cancer prevention, diagnosis, treatment and care. In this series, we try and give both patients and healthcare professionals tangible things that they and you can do when it comes to cancer. While we know that not all cancers are preventable or treatable or curable, there are things that we can all do that can make a real positive difference to the health and well-being of our family, our friends, our colleagues and ourselves. In this podcast, in previous episodes, we've talked about different surgical techniques, and we've talked about the difference they're making to the lives of patients. They're curing cancer, they're treating cancer, they're giving patients more and more time with their loved ones. That's all down to the amazing skill of the surgeons, but also the amazing technological advances and the new techniques that have been developed all the time. In today's episode, we're going to be talking about one of those techniques, and that's hypothermic intraperitoneal chemotherapy. Did I say that right?
You did.
Yeah. Or HIPEC. I can say the words, but I won't even try and explain what it is. I'll leave that to one of my guests today, Anna Minicozzi. You are a colorectal and robotics surgeon, and you're also the CRS and HIPEC lead at Barts Health. Hello, Anna.
Yeah, hi, hello.
Hello, nice to have you along. And we've also got Dr Angela Wong, Chief Medical Officer for the North East London Cancer Alliance. Welcome back.
Thank you.
Anna, let's start off with you then. Just give us a bit of a background about how you came to work in such an interesting field.
I joined the colorectal team at the Royal London Hospital in 2018, and previously I worked as a consultant at the Christie Hospital in Manchester. And the Christie Hospital is a well-renowned hospital, cancer hospital, and is one of the 3 centres in the UK where this procedure is performed. So this work at Christie allowed me to become an expert in this field, and there I developed and I performed a high volume of this procedure. But before I was appointed at the Christie Hospital in Italy, at the Verona University Hospital, we set up this service in 2006, and we performed cytoreductive surgery and HIPEC for peritoneal metastasis from colorectal and appendiceal cancer, but also for gastric and ovarian cancer. Unfortunately, at the moment in the UK, this procedure is not commissioned for ovarian and gastric cancer. There is no strong evidence so far to support this, but since 2010, cytoreductive surgery and HIPEC is indicated for colorectal peritoneal metastasis, and also for the treatment of pseudomyxoma peritoneae, that is a very rare and a very complex also disease of appendix. At the Royal London Hospital, we set up the service in 2020, and we started to perform this procedure just for colorectal cancer peritoneal metastasis. And we had really a good volume of patients that now are referred to us to perform this surgery. Clearly is a complex procedure that we perform with a curative intent, and normally we remove all the disease that we see in the abdomen. This clearly require many times the resection of many organs, and also what we call target organs. The ovary, for example, in female are always removed, falciform ligament and omentum are organs that we routinely remove just because it's easy that we can have some microscopic disease at the histology, and if we leave in the abdomen, there is a high chance that the disease can recur just in these places. After the cyto reduction is performed, we irrigate the abdominal cavity with a solution with a high temperature and the chemotherapy, and this will circulate for 90 minutes in the abdomen, and in this way we are able to kill all the cancer cells that we are not able to see. We can sterilize the whole abdomen with this chemotherapy. Clearly, because the chemotherapy is inserted in the abdomen, the chemo can penetrate into the cancer cells very easily and can be more effective compared with the IV chemotherapy that we routinely perform in metastatic patients.
So it sounds quite an extreme complicated procedure. What are the kind of side effects compared to, what you might call normal chemotherapy?
Yeah, it's a complex procedure because this surgery will require at least 9-10 hours of procedure, and the chemotherapy circulate for 90 minutes. So we talk about the timing could reach also 12 hours, and it's extensive the surgery because all the visible disease need to be removed. So this can require splenectomy, cholecystectomy, liver resection, a stripping of peritoneum in the diaphragm and in the abdominal wall, bowel resection, resection of colon, hysterectomy, bilateral sphincterectomy. So it's a very long procedure. So the complication of this surgery are high compared with a normal resection. And on top of this, the chemotherapy clearly with a high temperature can increase also the postoperative complication. It's very common that this patient can develop postoperative ileus, gastroparesis, and pancreatitis, and there is the high risk of anastomotic leak. And clearly, sometimes a patient will recover very slow, and normally the hospital stay is 12, the median hospital stay is 12-14 days, but clearly if everything go well. And there is an additional problem that the recovery also for the patient is a little bit long. We say that they need normally 3-6 months to come back in a perfect shape, just because the surgery is very, very invasive. But clearly, in one of the advantage to insert this, to administer this chemotherapy intra-abdominally is that the patient doesn't have all the side effects of the chemotherapy, because the amount of chemotherapy that we will find in the blood in this patient after the procedure is very low. So nausea, vomiting, and all the side effects of IV chemotherapy are not evident post-surgery. Clearly, patient can develop can become neutropenic and can have low white cell, can be anemic, but this is some things that we know that is correlated with the procedure. Clearly, the side effects are also correlated with the type of drug that we use during the procedure. And normally at the Royal London Hospital we use two different protocols, one with mitomycin C and another one IVFU and oxaliplatin intra-abdominal. The majority of our patients are treated at the moment with mitomycin C because there is some evidence from literature that this drug is more effective, reduce the complication, and if we use for a long period during the HIPEC, we have the best oncology outcome.
Anna, you mentioned there about the length of the surgery can be 12 hours. I can't even start to get my head around how you stay concentrated, how you stay focused for such a long time. Just take us inside your head, really, when you're doing a surgery of that length. How do you do it?
Yeah. I think that what gives us a lot of energy to keep going is sure the results that we see post-surgery, but this type of procedure is, I find this type of procedure great because I am not alone. I work with a lot of colleagues and sometimes my job is just to coordinate also the other specialty. So for one case, it's possible that I need the HPB, the urology, the gyne-oncology, the plastic. So you will see that in theater, a lot of other colleagues, consultants come across to help and do some part of this procedure. So this releases me from a little bit of tension and give me also the chance to have the small break. And but I think it's so nice work with this multi-specialty team that after you don't feel tired or you don't realize that it's just 8 or 10 hours you are in theater. And the other things is during the HIPEC, normally we can leave the theater and be around and wait that this chemotherapy, this circulation is completed. And you see that at this time there are my CNS, that are oncology nurse, that come to check the drug, administer the drug, so we can have also some small chat and we can have some small rest and release the tension.
Do you eat during the 12 hours?
I normally buy the breakfast and the lunch for all the team.
Breakfast, lunch, dinner,
absolutely, because we need to stay for all the day. So we have we rotate and everyone will have the lunch and a break.
Oh, it's extraordinary. I can't even imagine. I struggle to concentrate for an hour or two, having to, and I'm sure, other surgeries that you do as well, even if they're not 12 hours, some of the robotics, hours of real concentration.
Yeah, absolutely. It's a part of our job. Clearly, this is an exercise that we do for many years. So it's very important that we keep focus during the operation. Everything can compromise the outcome. So I think that there is no any surgeon that feel tired or feel hungry or want to go in any place during an operation, because what we want to complete the surgery in the best way. So it's like that we don't feel anything around us. And
you actually feel like you sort of thrive under that pressured environment where all the focus is on you. I know you say there's other people coming in and out, but you're the kind of main the main figurehead for that.
Yeah, absolutely.
Do you feel like you're someone that kind of like you thrive on that pressure?
I feel clearly a little bit of pressure, but because now it's many years that I do this job, I learn how coordinate the job, how try to have some time to relax in the same during the procedure.
Yeah. You've sort of figured out ways, and ways of relieving the pressure.
Absolutely, absolutely. Sometimes my colleague, we have a team, no, and we work together as a team. So sometimes my colleague come for a delivery section and say, "Oh, Anna, why you don't take a break?" No, we work in a way that everyone is comfortable in theater without any stress, and also we have clearly registrar that work with us, and they also are very keen to learn this procedure because it's not seen in every hospital in London. So they are keen also to do some things. So it's our also responsibility leave them to perform part of the procedure where there is no any is an opportunity for them to learn, and so also the help that we received from our registrar is very important.
So how long, maybe to either of you, how long has HIPEC been a thing? How long?
At least 20 years and this procedure was performed by Sugar Bakery in USA initially, and after started to involve also other country in Europe, and I think that in the UK our team at the Christie Hospital started this procedure around 2013, and this also because the evidence of this treatment was clear after a randomized trial from a Dutch trial in 2008. So slowly also other centers started to develop the procedure. I think the development is a little bit slow because you can clearly understand that this is an you need a good experience and clearly also the learning curve is very long. We talk about 150, 140 procedure to become an expert in this field. So it's important. You need have the expertise. You need the strong team around you, and for this. When I joined the Royal London Hospital, I immediately thought that this was the perfect environment, the perfect platform to develop this procedure, because we have all the specialty that can help to perform this procedure in a safe and in a great way. You need the HPB team to be involved when there are also metastases in the liver, and you need the gynae oncology when the uterus and the ovary are involved. You need the urology if you need to resect bladder of the ureters. So I think all hospital can provide this type of expertise all in the same place. So in Europe we have around 450 centers, and around 60 centers are in Germany and 40 in France, and in Italy and Spain we have around 30 HIPEC centers. Here in the UK we have 5 recognized national centers. 3 are in England, 1 in Dundee and 1 in Dublin. Clearly, at the moment, these are the recognized national center, but there are other hospitals that start to perform this procedure if they have the expertise in place.
Angela, we talk about taking control of cancer. That's the topic of this whole podcast. Not just this, but like new surgical technique and techniques like this. And I'm sure HIPEC has changed over the 20 or so years it's been around. But like new surgical techniques like this are very evidently a way that we are taking control of cancer.
Yeah, I absolutely agree, and I think that Anna coming to Barts Health with that experience has enabled us to develop this innovation and treatment in North East London, which is so important. I mean, I think one of the reasons that we wanted to present this today, because this is in particular a treatment for patients with advanced cancer, in which we are offering increased survival and outcomes from this particular treatment.
Because that's one of the amazing things I've mentioned her plenty of times in this podcast. A good friend, Dame Deborah James, she was, that's kind of my background of seeing someone who was diagnosed with stage 4 cancer, but using a number of really innovative and new treatments, both surgical and other things. She lived for more than 5 years when the prognosis wasn't anything like that at the start, and that's kind of where we are, isn't it? That the treatments and everything's sort of happening so quickly that what was maybe a couple of months 10, 15 years ago could be 5, 10 years or something now.
Absolutely, and I think one of the, which Anna's already described as needing the whole team. Why aren't there more centres? Firstly, you have to have the expertise, and then secondly, you have to have the broader team in order to do this. And in Anna's case, there was a bid into Barts Charity also for the equipment, and it was then having the equipment and the resource to actually initiate this that has allowed the Royal London Hospital and for North East London to build up this experience.
Anna, how has the procedure changed then in the 20 or so years that you've been involved? I know you're involved in robotic surgery as well. How has the actual procedure and the actual doing of the surgery changed?
Yeah, this is a very good question, because I started really early this procedure in Italy, and also for a different type of cancer. So I really saw patients have some more early recurrence than other, and so I had the chance to reflect why this happened. And what we notice in the last 10 years, this is because HIPEC also generate a lot of research on this field. I think this helped a lot surgeons and oncology to manage this type of disease. 30 years ago, patients with peritoneal metastases were palliative patients. This means that they were treated just with palliative chemotherapy, so the survival was very low. Now we offer this surgery with we give a chance to the patient to have also median survival of more than 60 months. And what we notice, that what we learned with the experience is that initially, mainly for colorectal cancer, we started to offer this procedure to nearly every patient, because we thought that there was the right things. Normally we have the score that allow us to assess what is the amount of disease in the abdominal cavity. This we call peritoneal cancer index score, and this the range is between 0 and 39. And initially we offer this procedure to every patient also with a 30 of PCI score, but now we know that this high PCI score is not associated, also if we perform the good procedure, unlikely we can achieve a complete resection, but we know that this is a prognostic factor, and the patient, the prognosis is not great. So in the last 5 years, we changed our cutoff, and initially was a 20 PCI score. We are happy to offer a patient now the procedure if the PCI score is 15. This means that with the experience we learned that clearly this is not the procedure for every patient. It's not the procedure clearly for to solve all problem in this type, in this extensive disease. So we are a little bit less aggressive, we can say, than before, but this is very important because a patient need at least 3-6 months to recovery from this surgery. So we also need to think about the quality of life. So if our effort to cure the disease can allow the patient to survive longer and with an acceptable and good quality of life, I think that the procedure is the indicated and we need to do. But if we are not in this position, I think that we need a little bit be less aggressive and think about what could be the life of this patient.
But I guess that's the case with any kind of new surgery, that you're learning all the time, aren't you? Like when to use it, when not to use it.
Yeah.
You know, the effectiveness in different patients. Angela, Anna mentioned about, you know, how many HIPEC centres there are in different countries, and I know there are so many factors, and you've touched on a couple already, so many factors that go into, you know, rolling out new technologies and things. But I'm quite a competitive person. Why do we only have 5 and Germany has, was it 50, did you say?
60.
60, sorry. You know, that seems quite a discrepancy.
So I think partly it's the way that it's commissioned, and I think the evidence currently has been that there isn't enough from a clinical and cost benefit to have this in more centres, and that is being looked at. I think in this case what is happening is we're building the experience. We're not necessarily getting the tariff that you would get for undertaking this procedure, but if you take the cytoreductive surgery, that's a complex abdominal procedure, and then you add HIPEC, together, that is enough to be able to do it. But I think it's really linking into this. You need the whole team. You need the radiologist to be able to confidently give you that PCI score, which will allow you to target the right patients to increase those chances of success. And then you need the surgeons and the anaesthetists with you, as well as our nursing support and the whole administrative team to deliver it. So I don't think it's a simple... It's as simple as, you know, we should have 50 centres. Yeah. We do need to consider how many centres in that low volume but highly specialised centres, so that you can build on that experience and the learning that has been described.
Anna, what do patients say when you explain HIPEC to them? Because I imagine it must feel to a patient, we're going to take out all your organs, we're going to pour hot chemotherapy into you. It must seem like probably a bigger deal to them than maybe it is to you.
Yeah, no, really, it's a difficult consultation. Yeah. And because it's a very complex disease and a complex procedure, so you need normally an hour to go through all this information and be sure that they fully understood what's.
Do they ever say no, I don't fancy that?
They never say no, right. Because the hope to survive longer is there. So I see many patients that are really happy that they have this chance to go ahead with this surgery. Because clearly sometimes they come from other hospitals where this procedure is not performed, and they know that this is the last opportunity to have some treatment cure. So they normally are very keen to have this surgery and are clearly scared because the consent form is a long consent form, and clearly the risk of complication is very high, but are very keen. Also because they come also with different, after a different consultation and very confused, and so the idea that everything can probably come back as it was before, keep them very strong and determined to go ahead with this procedure.
I think the concept of heated chemotherapy in the peritoneum, which is the lining of the abdomen, is also something that can be understood. You're giving that chemotherapy treatment locally, and it's something that is difficult to reach if you give it sort of systemically, i.e. as a drip through your vein.
And I think like Anna said, you're talking to people who in many cases will have quite advanced disease, and they're probably just at a point where they're like, you guys are the experts, you do what you need to do. let's talk about one of those patients then, because Anna, I'm sure we can talk about Jean-Pierre Dupont. I said that with a terrible English accent, but he's one of the patients you treated with HIPEC, and it's completely changed his life.
Yeah, absolutely. Jean-Pierre was one of our patients who went to this pathway, and he had also fantastic outcome after surgery. And unfortunately, he was admitted to his local hospital with a perforation, and he had 2 cancer in the colon. One of these in the sigmoid, in the distal part of the bowel, was perforated at the time, so they tried to fix just this problem as an emergency, and they performed just a stomach colectomy. But they find disease in the abdominal cavity, and so he started the chemotherapy and was regularly reviewed locally and also by other centers, and always he was assessed as not suitable for this procedure because the amount of disease was high, and with this PCI score, what we discussed before, more than 16. So at this point, and here I want also to give another information, the role of oncology in this field, very important. So far we discussed about the role of a surgeon, but I think the oncology is also the key in this treatment, because now for to manage every cancer we need a multidisciplinary team. The oncology in this setting is very important because in the last period we say that there was some change in the surgical process, but also in the oncology field we now see that we ask the oncology more neoadjuvant chemotherapy. We ask the oncology to administer chemo to shrink the cancer and to give us the opportunity to remove all the disease when we perform this surgery. So in this
just to come in, neoadjuvant means you're giving the treatment before.
Actually, before Anna carries on, just a really important point about the role of a lot of different people in the treatment of one person, isn't it?
Yeah,
absolutely. In this, in Jean-Pierre situation, the oncologist start immunotherapy because he had was a cancer who responded to immuno. So at this point we notice that the cancer started to respond, and we monitor for many months. We review imaging every 3-6 months. At the end, when we find the best results in terms of response to chemotherapy, immunotherapy, we decide to go for the procedure. So, but there was this very close work with the oncology that allow us to find the best time to do the procedure for this patient. And this is the key. Try to operate when is the time, because we have just one window. When is suitable, we need to do the surgery, because weight can be detrimental for the patient. And this was the case of Jean-Pierre. And he came to us, he was referred by one of our anesthetists that work in the HIPEC setting, and he is still now with us, and we have this local discussion with this close discussion with the local hospital just to manage together his care.
What an amazing thing, Angela, because he was initially given possibly a matter of weeks to live, and then you're talking about years afterwards. Doesn't seem that much in the lifetime of a person, but actually the time that you're giving to that person to spend with his wife, with his kids, it's absolutely invaluable, isn't it? And that's the impact of technologies like this.
Absolutely, and his patient story is so compelling, and we're recording this today, and we don't have video, but if you could see the sort of pictures of his family by the beach, and it's very powerful in terms of what extended life and quality he'd been given as a consequence of having HIPEC.
Yeah, so precious, and it's something that I imagine, you guys kind of see it all the time, but it's such a important thing, just to, even if it's 6 months or 6 weeks, even you might, go back to Deborah. She got to see her, her 40th birthday, her children go to school, and it's these kind of things are so important, aren't they, Anna?
Definitely. And I think in Jean-Pierre's case, you can hear that actually, how did he become aware of this procedure? It was actually through a medical contact.
Right.
And similarly, I have a friend of a friend who sadly has a diagnosis of colorectal cancer and wasn't aware of this. And so, again, she underwent this procedure, but by finding out about it through me, because I was aware of it, and because this was available at the Royal London Hospital.
So if you're not, if you're a patient that might benefit from it, and you're not in a part of the country anywhere near one of these 5 centres, how would you access this treatment?
I think that's one of the reasons for this podcast, to increase the awareness of the availability of this surgery and HIPEC in combination. It's really important, and it's available for cancers that are T4, so they've breached the bowel wall, and the cells are invading the peritoneum, which is the lining of the abdomen, as we've described. And in Jean-Pierre's case, he had a perforation, so by definition, that had breached the colon wall. So this is the group of patients who are potentially, who on their imaging are shown to have metastasis, that spread of the cancer into the lining of the abdominal wall, the peritoneum, who then would have to go through a process, an MDT meeting, a multidisciplinary meeting with all the colleagues who assess the suitability for going forward for this.
But I presume that if everybody that would benefit from it, wanted it, there probably wouldn't be the capacity in 5 centres to cope, would there?
So I think that then leads to the building of, firstly, we need to build the infrastructure and the expertise and grow that. And then I think it would push forward the case for it. I mean, when we look at the evidence as described, you look at a level where there's experience across a number of different centres, and often it's international. So then if you translate that back to the UK, and we've got smaller centres, it's really important as we do this that there's the monitoring and evaluation to prove the case for developing it, and then raising the awareness that this is available not only for patients but also for the clinic, for the colorectal teams across the country, and as we'll hear, the extending possibilities in other fields.
That was my next question then. Where does this go from here? Where does this, maybe not exactly the same surgery, but some of the same principles and the same techniques and the same some of the same elements, where could it be used in the future? The
Trust is now looking at introducing this HITOC, so in the field of respiratory medicine, thorax, for stage 4 thymomas, and also in gynae-oncology for ovarian cancers.
Our project initially was the multidisciplinary project, so the plan is now to move to the thorax. We can perform, there is some evidence that in thymoma stage 4 is possible perform the surgery, and the HIPEC that we call HITOC in the thorax is
so
the same
principle.
I struggle with my acronyms.
Sorry. And this is the plan at the Barts, because as you know, there is the big thoracic center at the Barts Hospital, and we already discussed and set up this service with our colleague thorax and oncology. The other step is also start the procedure for gynae patient with ovarian cancer that they spread in the peritoneum, and at the moment the standard is just to perform cytoreductive surgery, but there is some evidence that also HIPEC can help to improve survival in this patient. So the next step for us is just offer also cytoid HIPEC for patients with ovarian cancer. For the stomach, there is a strong interest from our oncology team. There is clearly small evidence because the stomach cancer is very aggressive. There is small evidence that this can improve prognosis, but also if there is no significant evidence, just recently from Japan we had some randomized trial that show some benefit. So also in this area we need to explore the outcome of this procedure, because clearly mainly in a young patient with just a small amount of disease in the peritoneum, cytoid HIPEC could be a great option.
So, I mean, what kind of, you're talking about sort of next steps, is this imminently, something we could see for other cancers, or are we talking 10, 15 years?
No, we talk in a short time. I need to say that we are nearly ready for the procedure for thymoma stage 4, and we will be ready probably in this before the end of this year for the ovarian cancer.
Fantastic! It sounds really exciting, but actually the it's not the only thing in the world of surgery, is it? There's so much. You're involved in robotics. That's another really exciting area, isn't it? And you were just saying to me before that it's something like that has really benefited your ability to do more surgeries, to not feel quite as tired maybe as you had done before. And
absolutely,
it's a really exciting world to be in surgery, I imagine, at the moment.
Absolutely. It's a specialty that change in. And since I completed my CCT, I needed to see that I completely changed the way how we treat disease. So this is very exciting. And if we think also about another of my expertise is rectal cancer, and also with rectal cancer, we now are in a position also to offer what we call watch and wait organ preservation, and this is not something that was possible 20 years ago, but now we can also avoid to remove the rectum if we treat with chemoradiotherapy and we have a complete response. In this setting, for example, we just received a grant from the Barts charity to set up a brachytherapy service. And this is an internal radiotherapy that we can administer in patients with rectal cancer and can allow us to achieve a complete response, so avoid the surgery and the stoma. So we see innovation in different fields, and this is very exciting.
And I think on that note, we do have to thank Barts Charity, because in both of these cases, they've allowed the sort of pump priming of this initiative to sort of fast track this innovation within North East London.
Just a final one, Anna. I'm always interested. We see lots of headlines in the papers, don't we, all the time about kind of where the UK, where England kind of sits in different world tables and things. I'm just interested, as someone who's come in from a different country, come in from Italy. What are your impressions of how different maybe the kind of cancer world is in this country compared to Italy?
When I came in the UK, I came just for a fellowship, and the plan was to come back home. But I was really impressed with the NHS system. I decided to stay for this reason. There are a difference between NHS in England and other system in other country, but I had also the opportunity to work in other centers. I was in Sao Paulo for 6 months.
But that was different.
Absolutely different.
I've worked in Brazil for a little while, but I mean, obviously not doing anything like this, but
but absolutely, because you are aware of another another system.
Yeah.
You see that the opportunity to have a cure is not for everyone. It's not there for everyone, and but I worked also I went in Stockholm and for another fellowship, and so I saw different system in Europe. I needed to say that I feel that the NHS is a great system and give the opportunity to everyone to have a treatment, to have the best treatment, because clearly I understand that the 5 centers in the UK are not enough, but the idea is to offer to the patient a procedure with the surgeon and the team who has more expertise in the country, is for the benefit of the patient. So I think that we are in a good position. We are innovation. The innovation, I clearly can talk about the trust where I work. There is the strong interest from the leadership team to innovate, because everyone understand how power is innovate, how important power for the patient, really, to achieve best results for a patient. So I think that I'm very proud to work in NHS and in my organisation.
There you go, Angela. That's a good.
It is.
Good recommendation, isn't it? And absolutely. I think a nice way to wrap up. Thank you so much, Anna. It's been absolutely fascinating. I'd heard of HIPEC before, but I couldn't have told you what it is. I feel a lot more educated now, and I think it's sounds like a really exciting thing that, you know, like you say, with more awareness, it's going to help more and more patients. And Angela, thank you as ever.
Thank you.
Thank you.